Hello, I'm Emma Cunningham. I'm a clinical academic, which means I work half my time in Queen's as a researcher and half my time in the Belfast Trust as a consultant geriatrician. So delirium, the official definition of delirium has really four main characteristics to think of. One is it's acute, so it's of sudden onset, and by that we mean it develops over hours to days. So if the things you're seeing have been present for months, that's not a delirium. Delirium symptoms occur, or they develop over hours to days. It's an acute onset. Second then is that there is an altered level of consciousness. So that can be decreased consciousness, that someone's quite drowsy or sleepy, or it can be thought of as being an increased consciousness, if you want to think about it that way, which means people are quite agitated, and they can be, agitated is really the best way to think about it. And there are different scales we can use. We'll talk in another video about scales, but things like Glasgow Coma Scale or the AFPU scale, they're objective ways of measuring consciousness. And the third thing is altered level of attention. So people will they'll find it very difficult to follow what you're saying, or it might be because they're drowsy, they find it quite difficult to follow what you're saying, and the different aspects of delirium do overlap. So inattention is a big one. And we'll talk again in one of the other videos about the different tools we use to measure attention. And the fourth main thing, so we have acuity, altered level of consciousness, altered attention, and the fourth, and you could argue the most important thing, is that it's due to an underlying cause. So this can be a wide variety of causes, like surgery, the addition of a new drug, the withdrawal of a previous drug, infection. There's a whole range of things that can cause delirium, but it's important, your assessment doesn't stop by identifying they've got delirium. Your assessment starts when you identify they've got delirium. So you wouldn't say, this person has abdominal pain, my job is done. You would say, this person has abdominal pain, we need to start looking for a cause. And similarly, once you go through the first few steps and establish that you think someone has a delirium, then you need to start looking, or the task begins then of trying to establish what are the potential causes. And there are often several overlapping causes. So the other thing to mention is that there are other facets of delirium. So one of the other key components is an impairment of cognition that wasn't previously there, but that can be very difficult to establish. So if you're just meeting someone for the first time, how do you know if their impairment of cognition was there before? Or if you do a very brief test and you don't find any impairment, you could argue, well, you just keep looking until you find one. So I think the best way to think about it is, and the other thing is that people with delirium will often have hallucinations or delusions, so they'll see things that aren't there, or they'll have misperceptions where they perceive something like a shadow to be like a person, or they'll have delusions, so they think things that aren't true. And whilst that's very common in delirium and very distressing for people with delirium and for their family members and for staff, it's not required to make a diagnosis of delirium. So to recap, the four main things when you're trying to establish if someone has delirium or not is, are the symptoms acute? Have they developed over hours to days? Is there an altered level of consciousness? Is there an altered level of attention? And to begin thinking about the possible underlying causes.